Ok. Ok. Bom dia a todos. Eu sou Eduardo Viana, sou cirurgião geral com foco em cirurgia pancreática. E esse aqui é o Pancreascast, que a gente está estreando como podcast do Clube do Pâncreas do Rio de Janeiro. E para essa estreia, a gente está estreando com chave de ouro uma entrevista com o professor Thilo Hackert, da, da Alemanha, da Universidade de Hamburgo. Todo mundo sabe, é um expoente da cirurgia mundial. E para essa estreia, a gente está estreando com chave de ouro uma entrevista. Então, eu queria dar boas-vindas. Thank you, Professor Hackert, again, for supporting us with another lecture slash interview. This time it's not really a lecture. It's a different format. We're going to talk about some points in pancreatic surgery and hear mainly Professor Hackert's personal opinion of some points of polemics, something like that. So, first of all, I'd like to ask about your medical career, Professor. How you started on surgery and how you came up with working on pancreatic surgery and dedicating your work life in researching pancreas.
Yes, Eduardo, first of all, good morning to Brazil, and thank you very much for the invitation in this new format I learned from your Pancreas Club, this Pancreascast or Pancreas podcast. I think that's an interesting format, and I'm looking forward to how we manage this with questions and answers and things like that. And first of all, a little bit about myself. My name is Thilo Hackert. I am currently the chairman of the General Visceral and Thoracic Surgical Department in the University Hospital Hamburg-Eppendorf in Germany. And I started, my career in Heidelberg University. So I did my medical school there, or a little more than 30 years ago I started. And then I went to the surgical department in Heidelberg to start my surgery education there. And from the beginning, it was more or less a little bit by accident because my former boss told me you have to go to the pancreas working group. So first of all, I did some basic research on pancreatitis and on pancreas transplantation. And then in hospital, it was quite logical that I did more or less the same thing clinically. And then I went into the pancreas group and worked, of course, then from 2001 under Professor Markus Büchler, who, of course, is very dedicated to the pancreas when he came to Heidelberg. And then I, of course, did the surgical education with him. And from 2014 on, I was the head of the section of pancreatic surgery in Heidelberg and became an assistant professor there. And then last year, in beginning of 2023, I was appointed for this position in Hamburg in this new department in the north of Germany. And of course, also here, the pancreas is a big focus that we try to be on, and that we try to do the studies, we try to do the surgery, and of course also the basic research, which is related mainly to pancreatic cancer in Hamburg, also together with the oncologists at the moment. A big focus is, of course, circulating tumor DNA, liquid biopsies, all of these translational things, but also the clinical studies. And we are interested very much in the robotic developments, how to proceed with this. We will talk about that potentially later. And then, of course, also some surgical techniques. Can you reduce delayed gastric emptying? Can you improve the results with different drains or anastomosis techniques? What has been done in the last 20 years, of course, but still we do see the problems with fistulas, with bleedings, with delayed gastric emptying. So there certainly is still more need also for good clinical studies on this.
Okay. We were talking previously that this system in Germany is quite interesting. So the hospital that you do all your career is not the hospital that you become the head of the department, right? Can you tell a little bit about the system? It's interesting for us.
Yes, this is kind of an academic history that when you work in a university hospital department, you can do all your training, all your career in this department, but you will never become the head of the department because you always have to apply in another university hospital to become the head of department. This is not really a written rule, but this is some kind of, as I said, academic tradition. And I think the background is that you think that a new chief can bring new ideas and so on, and there's not only the old staff is maintaining and is going on with the old ideas. I think that might be the background of this history, and therefore it is not, as I said, possible to stay in your department all of your life, at least if you want to be the chairman in the end. Otherwise you can of course stay there as a attending surgeon or a deputy or something like this. Yeah.
Okay, interesting. Let's talk a little bit of one of your biggest contributions to pancreatic surgery, that is the triangle operation, right? Can you tell us how you came up with that idea? What's the difference between that and a radical lymphadenectomy? Why did you feel that you have to push a little bit more besides the radical lymphadenectomy to achieve better results?
Yes, I think these are two very good points to be differentiated. Very radical lymphadenectomy has been investigated in 4 or 5 randomized studies when you take out all of the lymph nodes, the inter-autocaval lymph nodes and these things. And there has not been proven a real oncological benefit from this. But this is not the idea of the triangle operation that we have described in 2017. Actually, the idea was after neoadjuvant therapy. My former boss in Heidelberg, Professor Büchler, he said, we always have the problems of local recurrences that we all know. And especially after neoadjuvant treatment, you operate and you dissect and you don't know what you are dissecting because there is fibrotic tissue, there is always scars around the vessels. And then you tend to leave these things maybe behind because it's a little technically demanding, not to injure the vessel and these things. And then we decided to try to do this. It is a little bit like the so-called mesopancreas excision, which is, from my point of view, not really an existing definition, but some people have advocated this, of course. And it is basically take out all the lymphatics, the nerves, and the soft tissue around the arteries to clean this really up, with the idea to reduce the local recurrences and to be, as I said, radical as possible with your surgery. And this is the triangle operation. And then, of course, we also did this for non-neoadjuvant patients. This is basically the same from the technique. It's even easier if there was no neoadjuvant treatment because it's not so difficult from the scar tissue, from the fibrotic tissue and all of these things.
Okay, it's interesting that I've read your work, and a big part of the patients that were submitted to the first triangle operations were non-neoadjuvant patients. What, as you said, borderline patients. My first question is, do you do this operation for every case, even the resectable upfront ones? You do the triangle, or in this more early stages you were more economic in the dissection?
No, I do personally the triangle operation for every pancreatic cancer, even also for the resectable ones in the meantime. I don't do it for IPMN or for benign indications because then, of course, you take a risk of complications, which is probably not necessary. But I think for the cancer patients, you should try to do it for every patient just to be, as I said, as radical. And we know that also small tumor stages, resectable cancers, do have the risk of local recurrence as well as metastasis, of course. And we are not safe if it's resectable. Just take out the tumor without the rest, and then the patient is cured. That's not true, of course. Yeah.
And you started that in 2017, so it's 7 years now.
Mm-hmm.
Do you feel the results changed in terms of R0 resections and in terms of survival?
In terms of R0 resections, there are some differences, and there have been 4 or 5 at least retrospective studies at the moment for the triangle operation. We have also still performed this in Heidelberg, this analysis with 100 cases of Whipple and total pancreatectomies, where you can, of course, also do the triangle on both sides of the arteries. And the patients had a good rate of R0 resections. At the moment, I cannot tell you if it turns out into a better survival. That is still an open question. And there is a randomized study, multicentric, going on in Germany right now to investigate this. This study is now recruiting, but it will take probably another 2 to 3 years until we really have the results of this, oncological results, not the technical results.
Okay. And I've seen that when you come up to borderline cases, some of these cases in your work were operated on upfront, and other cases you have sent to neoadjuvant. How did you separate this?
Well, we have changed this policy in the last, I think, 5 to 8 years very much. At the moment, also in Hamburg, we of course have the MDT with the oncology, with the radiotherapy, and we follow the IAP guidelines with the anatomical, biological, and conditional resectable, borderline, and locally advanced definition. And this means that for the venous borderlines, we do upfront if the CA99 is not elevated too much, if there are no proven lymph nodes. For the arterial borderline, we always do neoadjuvant. So I think this is kind of the division between venous borderline and arterial borderline. And of course, we do neoadjuvant if the CA99 is elevated above 500 without a cholestasis. Of course, you have to always have a look at the bilirubin. And then we also do neoadjuvant for these biological borderline ones.
Okay. And when we take the locally advanced tumors, we know that these arterials compromises sometimes turns out not to be viable cancer cells and more fibroblastic reaction. So do you think that all locally advanced unresectable cases after neoadjuvant, if they remain stable, should go a surgical exploration and try to do resection?
Yes, basically, I think every case who has at least a stable disease, no increase of the tumor marker, should be explored. The only patients where I personally say it is not worth is if the venous inflow is compromised very much distally. If you have the SMV in its branches in the images, because this is really limiting. The arteries are mostly not really limiting because you can either divest the tumor from this, which is a little bit like the triangle operation, even maybe more radical, if you go on the artery shape directly. But the venous infiltration might be limiting. And then if this doesn't seem reasonable, I don't do an exploration for these patients.
Okay. And upon exploration, how do you decide if there is a viable tumor around the artery? How are you facing arterial resections? When do you decide to stop? When do you decide to go on with an arterial resection that we all know has a higher mortality and morbidity? You select some patients, you do the divestment first for everybody, or in some cases you stop the surgery?
Yes, this is always an intraoperative decision, which means that you prove you have no viable tumor by a frozen section, basically with the artery first approach on the SMA, on the distal part of the SMA. And if you don't have this, you can go for the divestment and can try to divest this. if you still have tumor, you must check if you have the possibility for reconstruction, if the artery is big enough towards the small bowel to do an interposition or a graft. This is, as I said, technically in most patients possible. And then you should plan an arterial resection if you are familiar with this type of surgery. If you, for example, have a transplant department where you can also maybe call somebody to help you with the artery or something like this if necessary. Otherwise, you should probably not try to do this. And then, of course, you have to check the vein, as I said, because also the superior mesenteric vein is sometimes the limiting factor when you cannot reconstruct it without a very high risk of thrombosis and small bowel ischemia afterwards. What I also like to do in such patients, if they have had a really good neoadjuvant therapy and you cannot expect any better response on the neoadjuvant therapy, that we do this in preparation with the IRE, with the irreversible electroporation, which means we have the machine in the room, we have the needles in the room, and when we say, okay, this is technically not resectable, we can add this IRE and just try to put some more local tumor control with the IRE along the arteries without resecting it then.
Okay. Still about these artery resections, if we are orthodox surgeons, like still now, an arterial invasion is it's if you will, it's you are authorized to stop the surgery. So it's still considered by orthodox protocols as an unresectable case. But we have been seeing that surgeons are pushing the limits and are doing more and more these kinds of arterial resections. In your opinion, do you feel the results are changing, or are we just doing a more aggressive operation, more technically demanding? The surgeons are getting better surgeons technically, mainly because of transplant techniques, as you said. Are we doing just a technical exercise, or are we changing the survival of these patients?
Yes, I think that's the most important point, that technically you can probably resect nearly everything, almost everything, but you also have to check your results, of course. And I think at the moment there are increasing numbers of some studies that support arterial resection. We had a big series in Heidelberg where we did this. There was a publication from Mark Truty from the US who has done 200 cases. There is Philippe Bachelier in Strasbourg who has done a lot of arterial resections. And those people have also published the results. We have also published the results from Heidelberg, which were approximately 15, 16 months median survival, which is not, I would say, impressive. But to explain this a little bit, that we did a lot of arterial resections in the past without neoadjuvant treatment, because this series was starting in 2003, where neoadjuvant treatment was not very common. And approximately 50% of these patients were only treated by neoadjuvant therapy in this series. And this can certainly be improved when you do a good protocol neoadjuvant, then if necessary, arterial resection, and then you must control your results. You should publish your results. As you said, not to do a technical exercise, which is nice, and in the evening you go home and said, oh, I did a great surgery today, but the patient has no benefit out of this. And this is also something that should really be done in specialized centers. And at the moment, I would say there are 5 to 6 centers around the world who do this in a higher volume, arterial resections. I mentioned some of the centers, and this should probably not be done by somebody who does this once in 3 years.
Okay, that's an important point. Complications of that, mainly, of course, if the patient survives, it's diarrhea. We were talking about that previously before we started. And how is your percentage of patients with a severe diarrhea, I mean, that really has an impact on quality of life, and how do you handle these cases?
Yes, that is probably the most important complication. You have one thing is chyle leak that you might have, which usually settles down after 2 weeks maybe. And then you have diarrhea in some of these patients. From our experience, it's approximately 15, 18%, 15 to 18% something. And the severe cases suffer for maybe 6, 8, 10 weeks. And from my experience, usually they come down when you give these opioid medications, when you give all of these things that block a little bit the diarrhea motility of the small bowel. But it might also be sometimes very severe that the patient needs parenteral nutrition, things like that. And this might really impair the quality of life. And you told me before we started that you also had this experience in a case with a very long-lasting diarrhea. This is possible. You have to tell the patients with this operation, but it's not my experience that it's so often. It's, as I said, 15%, and usually after 2 months, latest 3 months, the bowel somehow adapts to this situation.
Okay. Let's change the subject and talk about IPMNs. Mainly branch duct type IPMNs. We have seen like a pandemic of IPMNs, right? With the improvement of images and so on. So it's a very common situation. And in my experience, all the cases that I have operated on, even with worrisome features and some with high risk features, turn out to be a low-grade dysplasia. Do you think are we being too aggressive in this kind of pathology?
Yes, I think that we have been too aggressive in the past because of this fear of cancer. And this has been a learning process during the last 20 years. I always tell my residents, when I started med school, nobody knew IPMN. Nobody had ever described the situation. It was not the terminology of IPMN was not present at that time. So this is quite a normal learning curve, I think. But as you say, especially for the branch duct IPMN, we have become more restrictive. And at the moment, I think we still have to improve our guidelines and our practical handling with the IPMNs. And I always have also individual decisions that I discuss with the patients. You have patients that have a family history, that are very afraid of cancer or whatever. These are, of course, the ones where you feel better together with the patient if you take out the IPMN. There are some patients where you say we can observe, and the criteria, as I said, are not perfect. I think IPMN is the perfect entity where we need much better molecular markers, which will come up, but the size, the worrisome features is, not what helps us that much at the moment. Still, we have to deal with it in this regard, with the MRI, with the EUS, maybe some biopsy, some cyst fluid analysis. But I think we should really hope for molecular markers telling us this branch duct IPMN will become cancer and this one will be stable for the next 50 years.
Yeah, because I was thinking the other day that if we take a pathology like chronic pancreatitis, maybe the risk of cancer in a patient with chronic pancreatitis is much higher than a patient with a branch duct IPMN, even with worrisome features. And we do not operate on patients with chronic pancreatitis to prevent cancer, right? So
very few patients with chronic pancreatitis where I have done a surgery because of cancer prevention. Actually, I did have some of these patients who were 30 or 35 years of age, where we even did a total pancreatectomy because they had this from childhood, hereditary pancreatitis. They were not really symptomatic, but they were diabetic already. And you said right now, you can still technically do the operation. If you wait another 10 years, they will have portal vein occlusion. They will have all the collaterals. It will be technically simply impossible. And these are the patients where you rarely do a prophylactic resection in hereditary or chronic pancreatitis to prevent cancer. But potentially the risk is higher than in a harmless branch duct IPMN, but still chronic pancreatitis is a little bit underestimated in these terms, I think. And a lot of these patients finally don't die from their chronic pancreatitis. They die from their cardiac disease. They die from their liver problems and things like that. I think if they didn't have that, they would experience more cancer from their chronic pancreatitis.
And what is your opinion about more economics operations for branch duct IPMNs, like enucleations?
Yeah, that's an operation I personally really love, like to do this with a robot. And this is, I think, the perfect example. You have one branch duct IPMN, which is your index IPMN. And from the position, from the anatomy, it is possible to do an enucleation, and you have a reason to do this. Then I think this is the best you can do. You might have a 40% risk of fistula in these patients, but usually these patients don't get severe complications from the fistula. It might be 3 weeks of drainage or challenge, but not a complicated fistula usually. And I think this is the best thing you can do, indication for branch duct, if possible, enucleation, and if possible, try to do this robotically, because this is the perfect tool for enucleation. You have a visualization which is really amazing. You have these very, very nice instruments. You can do this very meticulously around the IPMN, and that's, yeah, as you mentioned, a good possibility, I think.
And how do you decide if you go to a formal resection or enucleations? It's just a matter of localization?
It's a matter of localization, yes. If you are too deep in the parenchyma, of course, it's hard to do an enucleation technically. If you have the suspicion that you have done any injury to the main pancreatic duct, you should probably also go to a formal resection in the same operation. And sometimes you really see this, that you have opened the duct sometimes. And I think these are the limiting factors. And if you have it in the body or the tail of the pancreas, of course, you are much more liberal to do a formal resection than if you need to do a Whipple procedure in an otherwise healthy pancreas with a soft tissue, small duct, and all of these things.
Okay, since you mentioned robotics, let's talk about robotics a little bit. First of all, how do you see the role of the robots in pancreas head cancer?
The role of the robot in pancreas head cancer is now becoming clear after we have seen the first 3 randomized studies on this. Personally, experience is that we have started this in 2016. Then we have increased our numbers a little bit, and then we have done a randomized trial on robotic versus open Whipple, not only for pancreas head cancer, but also for other indications. And from my point of view, clearly you should only first choose the resectable cases. Don't start with a portal vein resection with a robot. That does not make sense at all. Resectable cases, you can do this very well technically, but we have, as I said, now the first results from these RCTs, the one that we still performed in Heidelberg, which was published now, the one from China, which was published with a double number of the patients. And now this week or last week on the IHPBA, the Dutch colleagues presented their results. And finally, what is coming out is the robot is not inferior in the short-term outcomes. We have no long-term outcomes for oncology at the moment from these trials. Not inferior, but the only thing or the only benefit for the patient is a little quicker recovery, and the patients leave hospital 1 or 2 days earlier, which of course you can decide for yourself. Is this important for a pancreatic cancer patient, or is this not important for a pancreatic cancer patient? If you do a good robotic operation, no complications, patient goes home on day 5, perfect. if you do have a complication, it's exactly the same as in an open Whipple. The patient will be on ICU. You have to do maybe reoperation, drainage, all of these things. And the patient stays in hospital for 6 weeks. The robot doesn't change that.
Okay. And I managed to do the same operation. Do you feel are you doing the same operation that you do open? I mean, the triangle, the dissection, everything with the robots. And
yes.
What? How was this learning curve in your experience?
This is the other important part. You can do the same radicality with the robot. You can do the triangle with the robot. The problem is the learning curve, as you mentioned, because you do not feel anything with the robot. There is no haptic feedback, which means when you approach the SMA, you just see what you're doing. You don't touch what you're doing. And this, of course, makes you a little bit afraid in the beginning. And then when you have once identified, after some cases, you can do a triangle operation with the robot as well. But your learning curve is approximately 50 cases, I would say, which means one surgeon, 50 robotic cases, Whipple cases, not distals, but Whipple cases, then you have passed your learning curve. And this again tells you need 50 suitable patients for the robot for one surgeon for his education. And then you are the only surgeon in your center who can do it with a robot. Usually you need 2 at least who can do it, maybe even 3, which means learning curve, 100 patients, 150 patients.
Okay. I'll do a brief comment and a difficult question that probably you don't have the answer. Because as we were talking previously, your center is unique. I mean, you were saying you have 7 rooms dedicated for abdominal surgery each day. Like you do 10, 15 operations, not only pancreatic, but a lot of pancreatic operations. So it's a huge, high volume center where you can do a safe learning curve. Here in Brazil, we were talking about that 2 weeks ago in a group of pancreatic surgeons, that we don't have a center like that. So I have been trained as a robotic surgeon. I did 10 operations with supervision, 2 pancreatectomies, distal, hiatal hernias, inguinal hernias, colectomy, and now I have a certification of a robotic surgeon. I am allowed to schedule a Whipple operation. But how outside a center like that, general surgeon or surgeon with experience in open pancreatic surgery, how can we do a safe curve that we are not using patient's life, patient safety to learn?
Yes, because, if you want to do this, sorry.
Yeah, one question I was thinking about the other day is I was imagining how Whipple did like 50 years ago, 6 years ago. He did the first Whipple procedure, and then probably people started to doing that around the world without training. Probably there was a huge mortality that was not published. So I was thinking, in times of robotics, we're going back to Whipple times. I mean, surgeons are trying to replicate things that they are reading that come from centers like yours, and trying to replicate that isolated with no control. And I'm always thinking how we can do that around the world outside of reference centers without risking people's lives.
Yes, I'm pretty sure that this is something that can only be done in reference centers, which means also in Germany, there are 2 or 3 centers at the moment who do a I would say, relative high number of robotic Whipple procedures, 2 or 3 in Germany. So this is also not an operation which is done in every big center here just because of the learning curve. And as you said, when Whipple started his Whipple operation, people tried to duplicate this. Of course, they killed the patients in the beginning. And today we should not afford this because we know that you have all the workflow for the robotics to learn. You have the simulation, you can teach with the biotissue models, you can train your pancreas anastomosis with a biotissue model. You can have a tutor on site, you can go to visit for case observations. If you start your first Whipple and you have the patient numbers that you can do a Whipple 14 days later again and not 2 years later again, then you should have somebody on site who is proctoring you, who is really experienced, who helps you. If you do it on your own, learning by doing, that was the Pittsburgh group in 2004. They were the first in the world who started these procedures in a higher number of cases. And they were, of course, very careful, and they did this very well, I think. They didn't have this increased mortality, but it took them also, I say, 10 years to go for these 500 Whipples in the end and to develop this curriculum of training, of proctoring, of all of these things that we know today. And therefore, Whipple with a robot is something that you should certainly only do in a reference center when you have the facilities to do this learning curve, the numbers, and so on. And to also get a proctoring on site to do case observations and all of these things.
Do you think with the robots, laparoscopic Whipple it's best?
No, I have never done one. I will never do one. And you all know the Leopard study from the Netherlands, where they experienced exactly what you mentioned before. They had training, they had a learning curve for the centers. Still, they had a 10% mortality in the centers because they simply did it not often enough. And they stopped the laparoscopic Whipple in the Netherlands completely. No center does any laparoscopic Whipple anymore there. And I think this is the same. There are people in the world who can do a laparoscopic Whipple perfectly. Highly specialized people who do this. In every country, there is 1 or 2 centers doing laparoscopic Whipples. People who do nothing else but laparoscopic Whipples. Yeah. Fine. But it's also some procedure, not for the big majority of general surgeons. Don't try a laparoscopic Whipple. And from my recommendation, if you want to do minimally invasive today in 2024, the Whipple with a robot, not laparoscopically, just because of the suturing facilities, the reconstruction, all of these things.
Okay, nice. Let's change a subject about complications and reconstruction in Whipple procedure. When I visit your service, Professor Büchler's service in Heidelberg, I've noticed that pancreatico anastomosis was not done at all. I've seen Professor Büchler doing a total pancreatectomy to prevent a pancreatic fistula in a very soft pancreas, and did not think about the options of doing a gastropancreatic anastomosis that is safer, maybe safer in this condition. Why don't you believe in this kind of anastomosis?
Well, the first thing is if you have a larger service where you have 4, 5, 6 surgeons who can do Whipples, you need a standardization for your center, which means you should not have one surgeon doing a gastric anastomosis, one surgeon doing a jejunal anastomosis. You need to standardize this for your center. And that was what Professor Büchler did in Heidelberg. He said, we all do a pancreaticojejunostomy, which means technically we were all trained for the jejunal anastomosis. No one of us has done a pancreaticogastrostomy in a higher number. We have done maybe 5 or 10 of these pancreaticogastrostomies, but no one was really experienced with this standardized. And I think this is the first thing that you need for your center, kind of standardization. And if you have a really critical pancreas, it's not a crime to take it out, I think. The Verona group has now just launched this Tetris study, remnant pancreatectomy or completion pancreatectomy versus a high-risk anastomosis. And this is randomization is going on at the moment. We don't know what the result will be. But still, if you really feel very bad about your anastomosis to the stomach or to the jejunum, rather in these selected cases, maybe take out the pancreas. And then I personally think that the pancreaticogastrostomy in the long run is worse than the pancreaticojejunostomy, because you might have these complications where overgrowing of the pancreas, where you have these obstructions. Initially, you also have a higher risk of bleeding. We know this from some randomized trials that have been performed. And also these randomized trials have not really proven a benefit of the gastrostomy anastomosis. It has only shown, especially the German trial, what you do, often you do well, either stomach or jejunum. What you do not often, you have the same complications as somebody who doesn't do it regularly standardized. And therefore, it's just a kind of a standard doing the jejunal anastomosis instead of the stomach.
Okay, and what about delayed gastric empty? When I was there, you were doing this randomized trial between pre-colic and retrocolic reconstruction, and still is a main complication of this operation. And did you manage to improve that anyhow?
No, unfortunately not. The trials also here were more or less all negative, ante versus retro, resecting the pylorus, not resecting the pylorus. None of these studies really has proven any technical option to prevent delayed gastric emptying. So this is still unsolved. What we do, if we have the problem, we do an endoscopy, we do a dilatation of the pylorus, we try to improve it by that. But a prevention, I have no really guarantee how to prevent this. We still have the problem, mostly not so severe, but sometimes 2 weeks, 3 weeks is possible and is annoying for the patient. But it's not a life-threatening complication, at least.
You still remain around 30–40% of delayed gastric emptying?
Well, I think the clinically relevant, the B and C types, is approximately 15–20%, something like this.
Okay. And what about you said before that you sometimes do the irreversible electroporation to improve the margins. What are your thoughts as this procedure as a primary treatment for locally advanced cancer?
Yeah, sorry, I think then this was a misunderstanding. I do not use it to improve the margins. This is not the idea. I only use it when I recognize a tumor or a recurrence is technically not resectable and I have to stop the surgery. Then in selected patients, I have this as a kind of a backup option to do it in the same operation, put in the needles and do the electroporation. But this is, of course, something which is reserved for very selective patients. And I have really to tell you, I have no proof that this is beneficial for your survival, because there still the data are simply lacking. And the number of patients we are doing at the moment is small. We have done 6 or 7 of these cases in 1 year, maybe, since I came to Hamburg. So we will not be able to deliver big data on this. But I think it's a procedure with a low risk of complications. If you do not do an extensive exploration, just do needles in there, and finally you do the electroporation. It is safe and it might help. It might help. Local control.
When I was there in Heidelberg, you are also doing intraoperative radiotherapy. Do you think that the electroporation will substitute that? Do you still use it in some cases, or you have stopped?
Well, that's about the same. This is something you can do, which might be beneficial, but it has no proven benefit at the moment. I cannot do it in Hamburg at the moment because we don't have the facility. We are just preparing this and we are getting this machine now. But at the moment, I have no option to do it. So I would add it in selected cases, but for the same indications as IRE, more or less. Local control if you cannot take it out.
Okay. Okay, Professor Thilo, I think we have scheduled this 45 minutes. We just reached 45 minutes.
Perfect.
It was, I cannot thank you enough for that again, for having my residents at your service also. And you're always so kind with us Brazilians, especially. And we hope to invite you soon to a presential event here in our Pancreas Club.
Yes, thank you very much for this invitation, this online invitation now for this first podcast that you said or told me. And it's always a pleasure to come to Brazil again, of course. I really appreciated that very much in the past. And I hope that you will have a successful ongoing podcast with this, that this will be a format. I think it's a nice format as well. Not only a lecture, but kind of an interview and podcast, yes.
Yeah. Okay, thank you. Thank you. Obrigado a todos que assistiram, puderam assistir ao vivo. E vai ficar aí o link da gravação para quem não pôde estar disponível. Até a próxima. Obrigado.
Goodbye.
Okay. Yeah, I just finished the broadcast.
Yeah.
So it was nice.